weird me talking in there because I'm going to wander a little bit and then point. Okay. Hi. As most of you know, I'm doing the complex care course this year and I'm now on to my last assignment. For this paper we were required to come up with our own learning objectives that we wanted to get out of the course, and my biggest interest at the moment is fetal dopplers, maternal fetal medicine, and all these things that we're slowly branching off to now that we've got Dr. Gaiety here, so it's very fascinating for me. So yeah, my main focus was that. I'm seeing more and more people now in DAU, so having a really good understanding for myself was important, as well as getting it all out there because we're now doing more and more inductions and everything for abnormal Dopplers, so I just wanted to go out and get a good understanding. I also learn mostly by talking, so a practical session is a really good way for me to learn. And just in case you haven't noticed, I am recording it, so if you're going to say something, please be nice because I do have to send it in for assessment. Alright, how do you make this?
This one, right?
So for every education session you've got to have your learning objectives. So here's a list of what I'm hoping we're going to get out of my little talk. So everyone should be able to identify when a Doppler ultrasound is needed, have a basic knowledge of Doppler physiology and the different tests that we can do, and know where you can look for more resources, the charts and the graphs and the reference ranges, and for more information. Where's the other thing he's gone? Oh, how did I do that? Right, so as part of our midwifery scope of practice, fetal assessment during pregnancy is considered routine. A full assessment is all of these, which I thought would go up all at once. So fetal movements, fundal synthesis height, grow charts, palpation, auscultation, routine screening, plus minus CTG, plus minus growth scans. So I'm not going to go into depth about these assessment techniques because we all know what we're doing there. What we really need to know is what to do if we find something that's abnormal or has the potential to be abnormal. So the biggest change in our practice in the last 5 years has been the routine recommendation for grow charts for each woman from 24 weeks. So grow charts can be customised for each woman and can be done by doing fundal heights at each antenatal visit and growth scans if necessary. So our aim in fetal assessment is to detect any baby that may result in a small gestational age or IUGR. So the morbidities associated with growth restriction are lifelong and one of the biggest causes for fetal demise. So this little cluster of babies are the ones that we need to be worried about. Once identified, we can refer them for further screening and monitoring. CTGs, growth scans, lipo volume, Doppler studies. So for the sake of my assignment, I'm using the terms small gestational age and intrauterine growth restriction are interchangeable. Most resources now are using SGA rather than IUGR. Asymmetrical growth is another massive concerning feature. So that's when the AC is smaller than the circumference. This is usually a result of fetal brain sparing, and I'm just going to go into that a little bit later on. Monochorionic twins are also needing a lot more surveillance. So, you want your cows? Who wants his cows?
Where did you put them?
My
In your boat.
and my mum.
And your mummy. This is mummy cat. So we've got baby cat at home. You don't touch any buttons, okay? Alright. So when you do Doppler studies, so there's maternal reasons, which would be hypertension or PT, maternal antibodies, a previous SGA baby, and for other as sort of identified by the specialists. Fetal factors, SGA, MC twins, higher multiples, fetal anemia, decreased fetal movements, high drops, and other is required. So Doppler studies of the fetal circulation in IUGR and hypoxia have demonstrated increased resistance to flow in the umbilical arteries and redistribution in the fetal circulation. I've written so many words here that I actually can't read. So, Doppler studies. These measure the resistance to blood flow. We've identified that a Doppler study may be needed for a baby. Doppler studies are done by ultrasound. It's fast, non-invasive technique that can be done as frequently required. So most ultrasound practices will do these tests, and Dr. Getty also does her own scanning in radiology, antenatal and in DAU for her high-risk patients. The general idea of a Doppler ultrasound is to get an idea of fetal perfusion in utero to the main organs. It measures the resistance to blood flow in different maternal, placental and fetal blood vessels, thus how much oxygen is getting to the organs. Alright, so here I'm going to have to do a little bit of pointing.
Can you still hear me if I'm away from the microphone?
Yep.
Alright. So this is the Doppler fundamentals. So every blood vessel that we have has its own specific waveform. So this here is a waveform for a pattern of blood flow. The waveform is a systolic peak, which is this bit here, going down to the diastolic lowest value. Up here is the speed, and this is the mean velocity here. The blood flow always goes in a forwards direction, even when the heart is contracting or when it's relaxed. So each vessel in our body is different depending on its size, its caliber, elasticity, and the distance from the heart.
Yeah. So different Doppler tests. There's 6 main Doppler tests that we can do. The Bailey here just gives us a general idea of the main vessels that we're looking at. So we've got the middle cerebral artery, the ductus venosus, the umbilical vein, and if you imagine just a little placenta there as well with the uterine arteries on either side of that. So the main ones we test for are the umbilical artery, the uterine artery, and the MCA, and the other ones are done if the top 3 were abnormal. So the umbilical artery PI, so this is the first vessel that was ever to be evaluated by Dopplers. The flow velocity waveforms from the umbilical cord have a characteristic sawtooth pattern and with the arterial flow in one direction. The continuous umbilical venous blood sort of runs underneath, you see here in this top one.
This one here is the artery going this way, and this is the vein going that way.
Can I go back on that? So in a normal fetus, the resistance to flow, which we call impedance, decreases in the umbilical artery due to increased numbers of tertiary stem villi as the placenta matures. So the reasons why we do this test are up here. Abnormal readings are associated with insufficient placental function, which leads to growth restriction plus minus maternal hypertension. No, we don't touch that. Thank you. Do you want to go see some friends over there? I'll just walk on you. That's all right.
I haven't got anything exciting.
He's going to watch a drawing. Okay. So the umbilical artery impedance indices increase when there is a decreased end diastolic flow, reduced to placental perfusion, and intrautero placental insufficiency as seen in OGR. Absent or reversed umbilical artery end diastolic flow are particularly ominous. So this is what I said here.
These 3 are normal. This here is starting to get reduced. End diastolic flow, the other points are lower. This is absent, and this here is reversed. So that means that the blood in the artery is actually going forwards and backwards, forwards and backwards. So it should always just be going forwards. These are the ones that don't really have a good outcome associated with them.
So Rachel, you see the second one down where it's just a line underneath it?
This one here?
Yeah.
Yeah.
Is that line the...
No, that's just a line.
That's
on
just
the
happens to
track.
be there, okay.
Yeah. So that we would still see the vein sort of being underneath there.
Right, so it just isn't in
Yeah,
the
that's the
picture.
vein there, but yeah, it would be
Okay,
there.
that's fine.
Just the image that I could find.
Okay, so the uterine artery, this is a reflection of the resistance of the